So I'd like to start off by introducing the first speaker, who is Dr. Mazapuspavina, who is actually a friend of ours and also a member of the CPG, Asthma CPG. She's a consultant family medicine specialist from the Faculty of Medicine, UITM. And she will deliver the first lecture for this afternoon. And the title of her lecture is Asthma Basics, Risk Factors and Diagnosis in Primary Care. With that, I'd like to invite Dr. Maza to share her slides and start her talk.
Okay, Assalamualaikum. Good afternoon, everyone. I'm Maza. Okay, bear with me. I'm going to share my slides. Okay, can you all see my slides? All right. Okay, Bismillahirrahmanirrahim. Assalamualaikum again. Okay, so I am Maza from UITM Sungai Buloh. So for the first topic today is I'm going to cover about asthma basics, risk factors, and diagnosis in primary care. Okay, so this is the learning objectives. Number one, definition of asthma and definition of severe asthma. And we're also going to cover about risk factor. So there are a few risk factor here. Risk factor of developing asthma, risk factor for future exacerbation, which you need to recognize, and the risk factor for severe asthma, because we want to prevent life-threatening conditions. And thirdly is the diagnosis of asthma. Okay, first definition, what is asthma? So asthma is a heterogeneous disease with distinct inflammatory patterns. So we all know from our undergraduate medical school and your postgraduate education is inflammation basically. Is divided generally into two. Number one is the type 2, where you have a high T2 is driven by the T2 cytokines. So this type of asthma is actually cause more inflammation, elevated in IgE levels, and increase in FeNO levels. I will tell you about FeNO later in later slides. And this type of asthma is actually responsive to our inhaled corticosteroids and biologics. Okay, we're not covering biologics here because we are training for primary care providers. Okay, and the next group is the neutrophilic asthma, where this is associated with low or absent T2 inflammation. So this relate to the low or absent T2 biomarkers, normal FeNO levels, and usually is steroid resistance often observed. Here I show you a big picture, a big glance of asthma severity from stable to severe. So what do you mean by stable? Stable asthma when patients have well-controlled symptoms, use PRN or as necessary of reliever. There is no activity limitation. Patient can go exercise, swimming, okay? Normal lung function test, okay? Then we have under the stable asthma, where you can have mild to moderate partially controlled, or you can have uncontrolled asthma. So the partly controlled or partially controlled, you have the mild asthma where the symptoms or the patient needs to use reliever more than 2 times per week and low dose of inhaled corticosteroids. So low dose means your budesonide dose around 100 to less than 400 mics per day, okay? And then you have the moderate asthma where the symptoms increase as a daily symptoms. And then the some of night waking symptoms. And this patient needs higher dose of steroids or ICS LABA. Then you have the uncontrolled asthma, whereby this uncontrolled asthma, you have poor symptom control. If you remember the physician questions, 4 physician questions about asthma control, whereby one is a daytime symptoms, Number 2, use of reliever 2 times per week. Number 3, activity limitation. And number 4, night waking symptoms. So if patient has 3 out of 4 that I've mentioned above, shows that patient has poor symptom control, or the patient has frequent exacerbation, more than 2 times per year using the oral corticosteroid, because you know that when patient come from acute exacerbation, they will need a oral prednisolone for short term, okay? Then, or more than 1 time per year of hospitalization. Usually, this kind of patient of uncontrolled asthma, they affect by the, most commonly due to the modifiable risk factor shown below, whereby patient can have incorrect technique. So you need to check the patient technique again and again every time patient comes for follow-up, okay? Poor adherence, that is a very common, 80% patients say they adhere, guna doctor, guna, but actually patient might be poor adherence, which Miss Lee Ann will talk to you about this later, okay? And then smoking, okay? Sometimes the second-hand smoke or the environment can be the triggers, okay? Comorbidities, as you know, in Malaysia nowadays, the issues with obesity, okay? There are 50% of overweight and obese in Malaysia. So 1 in 2, okay, is obese, okay? And then if it's misdiagnosed, which is quite rarely actually. We talk about diagnosis later. So the next one is difficult to treat asthma. What is difficult to treat? Despite the high or medium dose of ICS, plus a second controller of long-acting bronchodilator. Usually if patient in step 1 or 2 or a low dose, we use the short-acting bronchodilator. But in patient difficult to treat asthma, they need a long-acting bronchodilator, and often influenced by the modifier factors. So this patient is considered under difficult to treat. If patient already maximum the optimization the medication and control the modifiable factors, meaning that the technique is correct, adhere, and already control the triggers, and patients still have symptoms, then we have severe asthma, which is a subset to the difficult to treat. So patient can have uncontrolled symptoms despite maximal optimization of the treatment, whereby we already exclude the modifiable risk factor. So what are the risk factors for developing asthma? So first component is the host or genetic. Okay, number 1 is female. Why female? Female because we have a lot of abundance of sex hormone, estrogen, progesterone, which can affect our immune response and inflammatory pathway. And estrogen also actually link or enhance the interleukin, which can also increase the eosinophilic activity. And our progesterone increase the airway hyperresponsiveness, so modulates the beta receptor function. Okay. Another way, because female size is a bit smaller than male, so their lung volume is smaller. So because of smaller airways, so because of that, the risk factor is higher. Another thing, being female, neuropsychological stress factor level higher, there will be higher level of anxiety. Okay, then we go for the next is atopy. So as you know that atopy, allergy rhinitis have higher risk of developing asthma, bronchial hyperresponsiveness, okay? And then if patient has a parental asthma, one of your parent has asthma, so that's why the genetic link is strong. So you always have ask whether in the family history, they have family history of asthma. So this is a basic knowledge lah, okay? And then for the environmental, exposure to allergen, like the house dust mites, pollen, cockroaches, okay? And then tobacco smoke, okay? So if the environment is not clean, so you can have like 4 times more likely to develop asthma. Same thing with the air pollution. Okay, so what are the irritants? Some patients have to deal with the occupational irritants. So those involved in nitrogen dioxide, carbon monoxide. So in some factories, sulfur dioxide, and also some particulate matter. Okay, so these are caused by the environment risk factor. Next is the perinatal or childhood. So younger maternal age have a higher risk of developing asthma, okay? And then maternal with preeclampsia so also have high risk of developing asthma later, okay? Maternal who smokes, especially during the pregnancy, they smoke, okay? And then those who born, if a baby born via Caesar, okay? So you know if a normal delivery with the lung expansion, you have a better APGAR score. So not those with the Caesar, okay? History of not receiving breast milk, okay? And then the lower pulmonary function of neonates, okay? Then I go next into the socioeconomic. Socioeconomic is another factor because of a limited access to education or healthcare. So patients tend to not to take care of their health, okay? And the last that I want to touch on and very important that you need to consider when you're seeing asthma patient is the comorbidities. Again, I have to emphasize on the obesity. Yeah? So obesity is a risk factor for developing asthma. And then as we understood, allergy rhinitis, chronic rhinosinusitis, or GERD. All right, okay. So for the, come again for the allergy rhinitis, actually 40% patient with allergy rhinitis can have asthma. Okay. So this just now is the risk factor for developing asthma. And this one is the risk factor for future asthma exacerbation. So number one is the history of medication use. So if the patient has previous history of severe asthma exacerbation, which require systemic steroid, so either oral or IV hydrocortisone, or patient need to be admitted within the past year, so that is a risk factor for future asthma exacerbation. So you need to ask this question when you're dealing with asthma, either come for follow-up or want to continue medication. Okay, you have to explore this history. Okay, number two, the overuse of SABA. You know, your salbutamol inhaler, the maximum in one canister, usually maximum either 100 or 200 doses. So if the patient have to use more than 3 canister per year, you can imagine about 600 doses per year that use. So meaning that kalau 1 tahun 300 over days, about 1.5 to 2 puff per day. So that's why it called overuse of SABA. So you need to ask that. Okay, sometimes patient cannot remember or don't want to tell exactly. You just ask. So how many canister you have used last year, for example? Okay, you have bought last year. And then the other one is inadequate ICS use or not on ICS or poor adherence to the maintenance therapy. This is a very common condition. Okay, patient can bring the pump here and there, okay, but actually patient not using it because when they use it, they cannot feel anything. So they think that the pump is not useful, okay, but they need to sure or we must tell them and emphasize that this pump is for prophylaxis, cegah you daripada dapat asma. So if you not use it, later you pakai all your blue pump, it doesn't work anymore, okay, and then you can have a future exacerbation. Next is the patient factors and technique. Okay, incorrect inhaler technique is very common, especially with the metered dose inhaler. We have a upcoming or already in the pipeline, the newer version, which is easy to inhale. Miss Lee Ann will tell you after this, okay? But if, because MDI is quite cheap and easily available, patient can buy over the counter. So this is a very common thing at the primary care. So you have to assess the patient inhaler technique. Okay. And also Miss Lee Ann will tell you that there's a video in the YouTube online that patient can, you can share with patient and patient have a look at that. Okay. The other one is the current smoker or e-cigarette or vape use. This e-cigarette and vape use is very rampant now, and with the unknown ingredient in the e-cigarette and vape user can really triggers a bad asthma or severe asthma because of an unknown triggers. I repeat again about the comorbidities. So those with obesity, GERD, chronic rhinosinusitis, And then especially those with confirmed food allergy, they have a risk factor for future asthma exacerbation. So food allergy, please confirm the what type of the allergy, meaning that how bad, how severe is the allergy. So if this anaphylaxis, this is a very bad, okay, but sometimes patients just have maculopapular rash with food allergy, just to ensure that there's no mucosal involvement. Okay, either from the look at the uvula, lip swelling, and all those. Okay, so it's very important to determine the food allergy. Okay, pregnancy. Previously, we used to learn the 1/3 rule. If you are pregnant, 1/3 you can be as usual asthma, 1/3 can be better asthma control, the other 1/3 can be worse asthma control. So pregnancy is another risk factor. And those with the high T2 or the T2 inflammatory markers, which has high FeNO and high blood eosinophil, is higher risk factor. Okay, and then lung function. To start off with, if patient did a spirometry, those at baseline, low FEV, especially less than 60%, okay, predicted, and also those with high bronchodilator responsiveness. Okay, so that is the risk factor for future asthma exacerbation. So how to diagnose asthma? We know asthma is a clinical history and symptoms. So a thorough history taking to identify asthma is a crucial for accurate diagnosis. Okay, so when you do the physical examination, patient might appear normal because there's variable of symptoms. So especially between exacerbation. So it is important to rule out other condition if you have in doubt. Okay, but typical signs of symptoms as we understood lah, tachypnea, bronchi, okay, a prolonged expiratory phase, okay, and decreased breath sounds. Be careful with decreased breath sound because some of us might think is a normal breath sound, but actually patient has decreased or even silent breath sound. So at that time, you can consider patient might have an severe or exacerbation, which you need to consider. So actually, there's no gold standard of diagnosing asthma, but spirometry, if available, is the objective measure to diagnose asthma. So with your typical history and physical examination, which consistent with asthma, so can send patient to perform spirometry, okay, with bronchodilator reversibility test, okay, meaning that perform a spirometry at baseline, if can order, then ask patient to take the bronchodilator, then repeat again the spirometry. So if the FEV1, what is the forced expiratory volume at 1 second and over the full vital capacity, which is less than 0.7 or less than lower limit normal, so patient is diagnosed as asthma. Okay. If it's not, then you consider further history investigation and alternative diagnosis. So these are the usual clinical feature for asthma: wheeze, cough, chest tightness, shortness of breath, okay? And symptom variability is very important. So it can be episodic. That's why it's based on the triggers. And then diurnal, usually late night or early morning. And then if patient exercise, okay? So the common triggers, again, infection, common cold, allergen, cold weather, irritants, smoke, haze, yeah, okay. History of atopy, allergy, rhinitis, and eczema, and then family history of atopy. So physical examination, don't forget to check the patient anthropometry. Patient obese, BMI more than 27.5. Check the patient vital sign to make sure that patient should be normal. If it's uncontrolled, it will show some signs, versus you need to recognize the acute exacerbation. Okay, then you auscultate lah. Okay, so investigation for asthma, as I mentioned, the spirometry. First, to demonstrate the airway obstruction. Number 2 is to demonstrate the obstruction variability or reversibility. So if you do spirometry, you will check the reversibility by giving the bronchodilator. Any improvement of FVC or FEV more than 12%, or more than 200 mils, so is a positive test. Okay, for the peak flow, we check can be two things. One is from the bronchodilator or from the diurnal variation. Prof. Andrea will explain to you about the diurnal variation or the peak flow later. Okay, so I skip that. The broncho provocation, you can forget about that. They're not covered in the primary care. Then number three, if you have the availability of tests, a blood test for the detection of T2 high inflammation, so check for the blood eosinophil. So if it's more than 4%, your differential count, check on that. So that is a high T2. And there is a test for IgE, serum IgE. You can send that. If some of you can send to the private lab. Okay, and then the third one is the pheno. This is an example of a spirometry graph. Okay, so normal spirometry FEV1 should be more or equal of 80% predicted, and normal FVC should be more than 80% or equal predicted. And the normal ratio of FEV1 over FVC should be more than equal of 0.7. If you look at the blue line, it's a normal, where here we have sharp rise of a graph and then a nice loop. As compared if patient is obstructive, so there is a lower of liter per second if the patient has obstructive asthma. So that's an example. Okay, this is another example. Okay, so I'll skip this just to make sure that you remember what are the cutoff point. So for spirometry, any airway obstruction, variability or reversibility, the FEV1 over FVC more than 12% and more than 200 mils following bronchodilator treatment. So results can be highly suggestive of asthma. So when to do spirometry? So before treatment, meaning that you need to test the patient, and then during follow-up at 3 to 6 months interval, and sometimes periodically when patient maybe stepping up or uncontrolled, that you need to reconfirm again. Okay. So a low FEV1 indicates underlying untreated airway inflammation and is a risk factor for future exacerbation. Okay, so this is the example of peak flow. Okay. All right. So for the peak flow, I'll skip. Prof. Andrea will explain on this. Okay. And this is the blood test. The eosinophil, I repeat again, either more than 150 cells per microliter or more than 4%. And the IgE more than 100 kilounit per liter. Okay. So take home message, asthma is a clinical diagnosis supported by history of variable symptoms and objective evidence of variable airflow limitation. So spirometry with bronchodilator reversibility is the preferred test, okay, to confirm the diagnosis. But normal results do not exclude asthma. So if you're unsure, can always refer. Okay, with that, I thank you.
Okay, thank you very much, Maza, for bringing us through the basics. Boring but essential. Risk factors important. Diagnosis also very important. I noticed that you said that I will cover some of yours. I hope you live up to it.